for our second presentations this morning.
Excellent. Thanks, Dr. Pat. Can you hear me and see my screen?
Yes, we can.
Awesome. So we're running low on time here, so I'm going to get going through this. So today I'll be talking about lateral extra-articular tenodesis versus reconstruction of the anterior lateral ligament, which what I want with my ACL. So I have no disclosures pertaining to this talk. My goals for today are to review the evidence behind lateral extra-articular tenodesis versus ALL reconstruction for augmenting the outcomes of ACL reconstruction. And I'm going to attempt to answer the question, which one would we want to be performed? And which one should we be performing? So let's start by defining the LET. What actually is the lateral extra-articular tenodesis? LET is an augmentation technique used for stabilizing the anterior lateral structures of the knee. It's performed by harvesting a portion of the IT band, leaving it attached to girdles distally. You pass it underneath the lateral collateral ligament and fix it proximally with either a staple or an interference screw. And the aim is to restore persistent anterolateral rotational stability that may be present after concomitant ACL reconstruction. An alternative to lateral extra-articular tenodesis is an anterolateral ligament reconstruction, which is typically performed by tensioning a hamstring allograft in the anterolateral ligament anatomic position. So why discuss this topic? During my time here in Charlotte during residency, I've noticed attendings performing both of these procedures with solid arguments for one and against the other. I wanted to make the decision for myself about which one I would provide in the future in indicated patients. So to help illustrate what I was seeing during training, I polled some of our sports faculty. 14 surgeons responded. 12 of those that responded stated that they did offer either of these techniques to augment their ACL reconstruction. And of the 12 that are performing ALL reconstruction or lateral extra-articular tenodesis, they're split down the middle. 50% are doing one and 50% are doing the other. So as a reminder, in 2017, Scott Dart gave his legendary grand rounds in the old CMC main auditorium. Sounds like ancient days. He made a case for the ALL. At the time of his talk in 2017, the literature was sparse concerning the relevance of this structure, and especially lacking in high-quality clinical data that justified surgical intervention for augmenting the anterolateral knee to improve ACL outcomes. But over the last 3 to 4 years, there's been abundant evidence that's emerged to describe the damage to the anterolateral knee structures and state how that can impair knee biomechanics and place increased strain on the ACL reconstruction. Moreover, recent literature has provided strong evidence that augmentation of the anterolateral knee may improve ACL reconstruction outcomes in high-risk patients. So an example of this new evidence is in this HASM article out of Vail, which showed that sectioning the ALL significantly increased translational laxity and internal rotation in cadaveric knees that had undergone ACL reconstruction. We also now have several high-quality clinical studies comparing ACL reconstruction with or without concomitant lateral extra-articular tenodesis. The most well-known of these is the stability trial, which was published this past year in AJSM by Get Good, as well as the group. This multi-center level 1 randomized controlled trial compared patients who underwent ACL reconstruction with or without lateral extra-articular tenodesis. All included patients were young and had high risk for ACL reconstruction failure with at least 2 of the risk factors on this slide. At 2-year follow-up, failure rates in this study were shown to be decreased by more than half with the addition of a lateral extra-articular tenodesis at time of ACL reconstruction. Similar findings have been found concerning ACL reconstruction with or without ALL reconstruction with allograft. In this 2017 prospective multi-center comparative study comparing patients who underwent isolated BTB, hamstring ACL reconstruction, to a large cohort of patients who had concurrent ACL reconstruction with ALL reconstruction, showed that concurrent ALL reconstruction with ACL reconstruction was associated with a 3.1 and 2.5-fold reduction in re-rupture rates compared to patients who underwent isolated ACL reconstruction. And for those looking for more evidence than this prospective cohort study, stay tuned for this multi-study level 1 randomized controlled trial that has just finished up 2-year follow-up and should be published soon. All that being said, I think it's obvious that there is a role for lateral extra-articular tenodesis or ALL reconstruction in the setting of high-risk ACL reconstructed patients, but I'm not here to talk you into the surgery. If you want that again, you can call Scott Dart up at UVA. But I am here to provide those of you that are performing anterior lateral knee augmentations data on the differences in outcomes between these two common techniques, and hopefully answer the question, which one should we be doing? The first study comparing the two procedures is this biomechanical study out of Vail. They began by sectioning the relevant anterolateral structures and performing single bundle ACL reconstructions on randomly assigned cadaveric knees. Specimens then underwent ALL reconstruction or lateral extra-articular tenodesis. Then the procedures were reversed and the opposite procedure was performed. The study re-demonstrated that in knees with damage to the anterior lateral structures, isolated ACL reconstruction did not fully restore internal rotation or anterior translational stability compared to the intact knee. They also reported that combining an ACL reconstruction with either anterior lateral ligament reconstruction or extra-articular tenodesis restored stability to what is seen in the intact knee. But if you look more closely at their data, you can see that both ALL reconstruction, which is the blue bar, and lateral extra-articular tenodesis, which is the red bar, restored internal rotation and tibial translational stability compared to the native knee, which is denoted by this black line. But lateral extra-articular tenodesis statistically constrained the knee much more than what is seen in the native knee. Another biomechanical study in Arthroscopy 2019 compared anterior lateral ligament reconstruction versus lateral extra-articular tenodesis in cadaveric knees that underwent ACL reconstruction. You can see in their results that both ALL reconstruction and lateral extra-articular tenodesis resulted in restoration of knee stability in terms of anterior translation, internal rotation, and valgus laxity. But looking more closely at the data, it is again noted that ALL reconstruction resulted in kinematics similar to those that are seen in the intact knee, while lateral extra-articular tenodesis tended to overshoot the restoration of anterior translational stability to levels higher than what are typically seen in the native anatomic knee. In the most recent biomechanical data comparing these two in the setting of concomitant ACL reconstruction was published last year in Arthroscopy. 6 knees underwent sectioning of the ACL and ALL, then subsequent ALL reconstruction and lateral extra-articular tenodesis were performed. Anterior translation and internal rotation stability were then robotically tested and compared. You can see here that both ALL reconstruction and lateral extra-articular tenodesis in the setting of ACL reconstruction restored knee stability. They found no significant differences between either technique at any knee flexion angle postoperatively. And after reviewing all of this biomechanical literature comparing ALL reconstruction to lateral extra-articular tenodesis, I think we can all agree with this recent editorial by Dr. Vanderlist, who concluded it's time to move on from biomechanical analyses and direct future work to clinical studies. However, I knew I could find some type of clinical outcomes comparison, so I dug through PubMed and found this meta-analysis. This is a clinical outcomes comparison between ALL reconstruction and lateral extra-articular tenodesis in the setting of ACL reconstructed knees. The meta-analysis identified 16 studies comparing 1,048 patients who underwent anterior lateral ligament reconstruction with their ACL versus 394 patients who underwent lateral extra-articular tenodesis with an ACL. When looking at the pooled outcomes data from the included studies, the meta-analysis found that patients who underwent anterior lateral ligament reconstruction had a lower chance of having a high-grade Lockman at 2-year follow-up. However, compared to those with a lateral extra-articular tenodesis, there was a 10.8% of having a high-grade Lockman at 2 years. On the other hand, pivot shift grade as well as improvement in Lateral scores appeared to be similar between patients who underwent either procedure at final follow-up. But at the end, remember that this meta-analysis was fraught with limitations, including extreme heterogeneity, including inclusion criteria, patient population, as well as indications between the studies that were included. So I would take that information, the clinical information, with a very small grain of salt. So that's it. Although recent literature does provide evidence that anterior lateral ligament reconstruction or lateral extra-articular tenodesis can improve ACL reconstruction outcomes in high-risk patients, we have very limited data comparing the two procedures to each other. So if I had to pick a winner between ALL, Recon, or LET, I would say that they both win. But there are some other variables to consider and balance when deciding between lateral extra-articular tenodesis with an autograft or ALL reconstruction with an allograft, obviously such as surgeon preference and skill set during training, patient wishes concerning allograft placement, viral transmission with allograft, which is exceedingly low, especially with modern grafts, the high cost that can be associated with ALL reconstruction compared to LET because you need 2 implants as well as an allograft, and then the potential for cosmetic defects that can be involved with the IT band harvest during a lateral extra-articular tenodesis. One may also argue that based on the biomechanical comparisons that we discussed between LET and ALL reconstruction, it appears that lateral extra-articular tenodesis has the potential to over-constrain the knee and lead to early lateral compartment osteoarthritis. This seems like a reasonable concern, but these biomechanical over-constraints have not translated into clinical problems, as evidenced by this recent meta-analysis in 2017 that concluded ACL reconstruction in the setting of lateral extra-articular tenodesis did not increase risk of osteoarthritis with 11-year postoperative follow-up. So in summary of the literature, we can deduce that both anterior lateral knee procedures were shown to restore knee biomechanics better than ACL reconstruction alone in the setting of severed anterior lateral structures. Biomechanical data suggests that appropriately tensioned anterior lateral ligament reconstructions may better reproduce anatomic knee kinematics, while lateral extra-articular tenodesis has the potential to excessively stabilize the knee. Clinically, anterior lateral ligament reconstruction may allow for better anterior stability when compared to the lateral extra-articular tenodesis, but both tended to restore stability to internal rotation and knee valgus. Obviously, we need a good randomized controlled trial comparing ALL reconstruction versus LAT versus neither in the setting of ACL reconstruction. So to deduce this down to some take-home points that I wanted to provide with everyone who is performing these procedures, it's obvious and it can't go without being said that appropriate tunnel placement and appropriate ACL technique always trumps the decision to proceed with an extra-articular tenodesis or an ALL reconstruction. These augmentations are not a substitute for appropriate technique. Lateral extra-articular tenodesis and ALL reconstruction is indicated for very high-risk patients or revision patients with other risk factors. Based on current literature, it does appear that the anterior lateral ligament reconstruction and lateral extra-articular tenodesis can both be performed with apparently equivalent clinical outcomes based on recent literature. There's no good evidence that either of these augmentation techniques leads to early osteoarthritis, and this theory all came from a SNOMAS consensus agreement from 1989 that has since been debunked. I'd like to thank all of these attendings for filling out the previous survey and giving some information and input on this talk. Thank you.
Brad, that was this is Dana Pisacki here. That was a great summary. This is a controversial, tough topic, a hot button issue in sports, and I think I applaud you for presenting it the way that you did. I think there are very good arguments on either side of this debate. I think, my personal opinion, I'm a bit of a skeptic. and would not claim to have, greater wisdom in this area than anybody else. The thing that worries me about this approach surgically is my personal sense, my fear is that this is a surgery looking for an indication. And I think some of that suspicion comes from having lived through the double bundle debate with ACL reconstruction and seeing that you can create biomechanical results depending on the design of your study that support your pre-study hypothesis. And if you look at all the biomechanical studies that you referenced, and there are several others out there as well, where the lateral capsular structures are sectioned and then compared to various reconstructions after the fact, I don't think anybody out there doing a lot of complex knee surgery would disagree with the concept that if you don't give back some of those restraints, a simple ACL reconstruction is probably not going to normalize the knee. The problem with that is that there are no clinical studies that have suggested that degree of anterolateral ligament or lateral capsular injury actually occurs in the clinical realm on a routine basis. And the clinical data that's out there, the Get Good paper you mentioned, among several others, do not establish pre-trial the presence of significant ALL injury. And so they took a cohort of patients who were, many of them ligamentously lax, performed a soft tissue only reconstruction, did not quantify activity level, which we know has a big bearing on failure after these procedures, and performed these procedures in some and not others. And without identifying that the ALL was the issue pre-study, they were doing presumably these reconstructions on patients who probably had pretty normal lateral capsular structures. And so that calls into question for me whether this procedure is actually achieving the outcome that we're seeing clinically in terms of decreased revision rates or decreased failure by actually solving a problem that's there. And it may be achieving an outcome through a non-desirable outcome. In other words, it may be a non-anatomic break that's applied to the knee that may have undesirable consequences downstream. And I think our tendency as surgeons is to look for a surgical solution to perceived problems. And I fear we may be overreaching on this one. I think the ALL and LET procedures, the fact that they both work pretty much the same, is another cause for concern. It suggests to me that there's a lot of variability in the anatomy and the lateral aspect of the joint. These are not anatomic reconstructions. And if they're both working the same way, we may be emperor who has no clothes type approach here, saying it's decreasing recurrence rates and therefore it's good. We may not be solving the real problem here. And I'm interested in Jonathan Rebo's perspective on this because he has a real passion for understanding return to play issues with ACLs. I personally think failure rates with ACLs, once you optimize the technical aspects of tunnel position and reconstruction, graft choice, et cetera, it's probably a neuromuscular issue postoperatively and activity level that defines whether patients have a failure. And that ALL and LAT reconstructions, while they probably do have a place, routinely, I worry, maybe over-operating on people and solving the problem potentially in an overly operative way. And you're going to have complications with more surgery. There's just no way around it. So that's my 2 cents.
Dana, this is Jonathan. Can you guys still hear me?
Yeah, we can hear you.
So, thanks for kind of that segue. My take on this really does, like Dana said, come from the angle of return to sport and how do we do that safely. And the research I've done over the last really 5 or 6 years has focused on that. What you find is that when you operate on adolescents, for better or for worse, failure rates are higher. So if you look at all comers in adolescence, 1 in 3 will have another ACL tear before the end of their active years. So, if you're doing 100 ACLs a year, you're seeing a lot of kids come back with either graft tears or contralateral tears. And so in the unique population that I see and Christian sees, this is a real problem. To Dana's point, neuromuscular strategies, so good rehab and a good criterion-based decision to return to sport has been shown to reduce the risk of injury by 83%. So that clinical magnitude is actually even larger than the LET. And so I'm a huge believer in the neuromuscular strategies for reducing re-injury. I do think there's a couple select populations where this operation does play a role. For me, it's the 8th to 9th graders that Frank Cordasco and the group at HSS have identified, kind of the 12 to 14-year-old girls and like the 13 to 15-year-old boys who have an incredibly high risk of re-injury no matter what we do, about 20% in most studies. So I have been incorporating the LET in that population due to their documented high risk of re-injury, even with good sort of return to play decisions. One technical consideration for Brad as you're deciding between these options, in a small 13-year-old female femur, your risk of tunnel collision with an ALL free graft and an ACL is about 100%. And if you're additionally trying to avoid the physis, you really want to have as small of a bony footprint as possible. So I've preferred using a suture anchor, a very small, like 1.8 millimeter anchor for an LET as opposed to doing a free graft reconstruction. And that's just sort of a unique thing in the pediatric population. I think the other situation where this is really helpful is revisions. You know, if you have a good ACL that failed for no apparent reason, I like to incorporate this into the revision, or the really, you know, sort of hyperlax, hyperextensile patient. And that was, I think, what Alan Getgood was getting at in his study. So that's kind of where I see it playing a role, but I agree with Dan, it's not a substitute for good neuromuscular rehab and safe return to play decisions.
Hey, this is Fleischle. Can you all hear me?
Yep.
Yeah, so I'm a believer. I think the anterolateral structures, whether you call it a midcapsular ligament, like Jack Houston described when I was still in grade school, or whether you call it an anterolateral ligament, doesn't matter. But I do think those structures play a role in backing up the ACL and can, you know, help prevent recurrence in high-risk athletes. And so I've been doing a tenodesis, IT band tenodesis for the last several years, which I learned from Alan Getgood, and think it's been helpful to prevent recurrence. I use it on primary ACLs and if they're ligamentously lax, as Rebo suggested, and the revision setting, I use it very commonly where you know, you're worried about recurrence in chronic ACLs that are really unstable with 3+ pivot shift. I use it as well because I think the secondary structures are stretched out and that can lead to recurrence. I respect Dana's opinion that it may not be anatomic, but I think backing up the ACL in those subgroups is important, and I use it. In terms of LAT versus ALL, I don't think it makes a difference clinically or really biomechanically in terms of most studies. And we haven't shown a clinical reason to select one versus the other long-term, but we need more data and longer-term data. But great talk, Brett.
Brad, great talk. I don't have anything to add. As you know, I'm a naysayer on this topic. I'm in the no category, but would agree with what's been said that if the patient has failed ACLs previously and you're not certain what the cause is, or if you think it's because of a pivot shift and stretching out of the secondary restraints, or perhaps some of these very, very high risk young adolescent females in particular that have ligamentous laxity that are prone to failure, those would be the groups that would make the most sense.
Yes, sir. Maybe the revision with no reason for failure. The initial technique done perfectly and there was no reason for failure. Yeah. Maybe even have a gone fracture that is hard evidence that there's anterolateral damage.
Yeah. Great presentation.